Hi, welcome to Room Now. This is Dr. Artie Kavanaugh, and I'm here with my colleagues, Dr. Eric Ruderman, Dr. Jack Cush, and Dr. Alexis Ogdie. And just got done with the ACR 2020 conversions, and lots of stuff presented there, lots of abstracts, lots of posters, lots of oral presentations and summaries and stuff. So we're going to talk about psoriatic arthritis tonight, and we're just going to ask our panelists kind of their takeaway from the meeting. Now it's a lot, as they always are, of a few intense days of looking at a lot of data. So what is it that is you think the most important takeaways from that? Eric, let's start out with you.
You know, we looked at the whole, I looked at the meeting. It was a different meeting than usual because there wasn't a lot, or not than usual, there wasn't a lot of new therapies, which we sometimes look to these meetings for. There's new stuff, there's new pathways, there's new things. There was one new, treatment trial with deucravacitinib, which is the TYK2 inhibitor. And other than that, a couple of sort of phase 4 trials of some of the drugs we already have, and a lot of stuff on, managing psoriatic arthritis and more sort of thinking about approaches than managing. The other new therapy that was there was the upadacitinib, though that wasn't really new because it had been presented at EULAR previously, so it was represented at ACR, and for a lot of people, obviously, that's going to be the first time that they saw it, but it wasn't something new. We knew it was sort of out there, and the data had been out there for a while. So that kind of made it a meeting where you had to sort of look around for something that was really, game-changing, basically.
Alexis, what do you think? An abstract or a presentation or something that really caught your eye from this meeting?
I think there were a couple things. One was, so I think a general theme of kind of setting up for the idea of predictors of psoriatic arthritis, both in terms of a couple studies examining a prediction rule for psoriatic arthritis at 1 year or 5 years among patients with psoriasis. Not fully baked yet, but really nice work that's hopefully going to evolve into something more significant, like a risk score. The other one was one that we presented, which was kind of what's going on in the time period up to the diagnosis of psoriatic arthritis and how are different providers coding different things. That has meaning in terms of if we're going to build algorithms within a medical record, how we might code differently for different providers in terms of what people are putting into the EMR. And then smart devices. So thinking about using the cell phone or your Apple or phone or Android in terms of accelerometer and goniometer, just to understand how movement patterns might change over time on the way from psoriasis to PSA. So that theme was there. The second theme that I thought was interesting and kind of discussed a lot at the very least was guselkumab presented their data for axial disease. Again, we saw that previously at EULAR, so nothing terribly new for us, but looking at BASDI changes among patients with radiographs done at their local institution and how those BASDI and those people changed among with use of guselkumab versus placebo. There was a parallel abstract, on the other hand, that from our group that showed that BASDI really doesn't change any different in patients with axial disease compared to those with peripheral disease alone. So really kind of questions whether or not we can be using BASDI as a marker of axial disease.
Kind of like a back version of the Rapid 3, huh? Back rapid.
Exactly.
It wasn't very specific. It actually picked up sort of disease activity in general, which was an interesting thread because there's this whole, idea now to try to break psoriatic arthritis and psoriatic disease down into different domains and try to figure out treatments by domains, which makes a lot of sense, except that if you don't have outcomes that can figure out which domains are going to respond to which treatments, then you can't get very far with that. And so it was a bit of a challenge. This whole idea of separating out it was interesting stuff. If it's separating out sort of axial psoriatic arthritis, it's hard to say it's really important to separate that out if you can't separate out outcomes and show that those people do worse in some way or another. And then you can't look at treatments if you can't sort of hone in on that particular area.
Jack, what'd you take away from the meeting?
Well, to your point, obviously Rapid 3 works in all disease, including axial spondylitis and psoriatic arthritis. So finding a better version of that, I don't know. One of the things that, I covered a lot of RA, but I looked at a lot of PSA stuff. Found it interesting that machine learning found its way into PSA as well. And really in the one area that I thought was maybe the greatest need, and that's reading images. I saw that your group looked at that information. I found that really compelling because, I really think we're not very good really at looking at images or certainly quantifying them. But using machine learning to score images for the spine, I think that's really compelling. And I think that could be, that's one of the machine learning things I'd like to see actually translated to practice.
Yeah, I think the radiologists are, they're definitely being, it's like Terminator. They're being replaced by the machines. And in this case, I think it's good because if you don't have a radiologist who cares about the spine, you're never going to get good information from it. And there's such wobble. I mean, how many studies have we seen in the spine where the local read was that if they had the spinal involvement, then the central read is no. I mean, come on, that's not data.
I mean, there's a lot of places that help. So that's great for studies, right? Because then you can standardize what's going on in the studies. You can read them centrally, but it saves a lot of time and money by having it read sort of a standard computer way. But it's it's potentially very helpful in practice, right? So if you've got if there's an algorithm that's developed, if there's a machine learning algorithm, and once this is set up, it should be sort of generalizable. You could export it to, and it ends up being sort of part of the software locally. And then you get an image, and then as the rheumatologist, you don't have to feel obligated to sort of figure out how to read the MRI because you don't trust your radiologist. You don't have to have a radiologist who knows what they're doing. You can get a report back. I mean, it's like getting a lab test, basically.
Or remember that abstract that Jose had last year with the MRE.
Mhm.
So if our GI colleagues get an MRE and the radiologist doesn't have to go, oh, geez, I hate looking at bone. They could just, push a button and it'll give a good bone reading to see if there's any axial involvement. Then you get double value out of every MRE. And they're doing more and more of those, it seems.
I mean, you remember a million years ago when you had to have a good pathologist who could look at your ANA plates and figure out the pattern and figure out.
How old are you?
No, but that's not that far back. I mean, it is, and I remember that when I was, in training. I mean, that's not that far back, and now it seems like crazy, old, antiquated. And I think in 5 years we're going to say the same thing about having a radiologist try to score a sacroiliac joint on an MRI. It probably doesn't make sense.
That microscope, Artie, that microscope is right next to your VHS machine.
I think the other thing we saw that should be extended to tendons too. I mean, we saw with the Achilles study, they looked at baseline. People had to come into this randomized controlled trial using secukinumab to treat enthesitis of the Achilles tendon. They had to have enthesitis demonstrated on imaging locally. And what they found after central reading was only half or so of those actually had real enthesitis in the way that should be read. So I think that we have the same problem in the spine that we have peripherally as well. So maybe we'll see more standardization of enthesial readings on MRI as well.
The problem, though, potentially is a lot of times you want the image to show what you want it to show. And if the computer says it doesn't, then you're stuck with that, right? Then you have to live with that. And people may say, well, I don't know that I believe that anymore. So it's going to be a work in progress.
And radiologists will continue to have jobs for that reason. So.
Yeah, that's true. I mean, but they're doing this in other fields too. They're already doing this kind of stuff, looking for, for lung nodules on routine chest, x-rays and things like that. I mean, this is the future in imaging for sure. So
let me ask you guys, I thought it was an interesting sub-analysis. As you said, it wasn't new necessarily. The EXCEED study, the sub-analysis by sex. Because generally, when you go into a clinical study, you avoid some of the influence, like methotrexate in psoriatic arthritis studies generally doesn't do anything because you have to get in the study with disease activity. It doesn't matter if you're on it or not. But here, there was some pretty sizable differences in outcomes based on sex. That seems like that must be a real thing.
Yeah, I mean, people have been talking about this for a long time. There's plenty of studies that show that even at baseline, women start higher on their patient-reported outcomes than men. What was fascinating in this study is that the change is also different, and this is showing this in a very controlled environment as opposed to maybe a different time points in an observational study. So at least we have that kind of internal consistency there. But what's interesting is it also played out within the skin, which was fascinating to me because it's, we think of maybe this is more of a subjective outcome difference, but it wasn't. It was actually across more, objective outcomes like the PASI, for example.
So is this an issue of the way differences between men and women, the way they seek, medical attention and how often and quickly and whatnot? Or is this really pathogenic like seems to be in spondylitis, where, women just present with a different disease and later and stranger manifestations that make it more delayed in diagnosis?
That's the big question, Jack. And unless you start to break up studies or stratify studies by sex, you can't get to that, right? That's the million. There are certain differences. Women tend to have more pain, and so that sort of changes things. Women have more radiographic change. I mean, that for sure is there. So there are differences, and they show differences in outcomes by gender in terms of rate of change. That was subtle, but especially if you're going to compare two studies head to head with small differences, which is what this was about, right? This was the EXCEED study was adalimumab and secukinumab, where they both work very well. And so you're looking for small differences. And so if gender can change things and you have a gender imbalance in the two arms, that's going to change your outcomes if you don't account for that. So it could be something to be focused on, particularly as we do more head-to-head studies.
Yeah, if this was a register you're talking about, Jack, then yeah, it said, well, maybe patient characteristics are different and how they present to you as a physician is different. But this is a clinical trial. You had to have this much activity to get in the study. And it's not like they were looking for men or women. They were just looking for eligible patients. So to me, this seems really that it's very clear that there's a disease, a difference in the disease. And maybe we have to stratify more.
Yeah, I agree. And I think more studies to really understand biologically what could be driving some of those differences. I think we have this preconceived notion that there's more fibromyalgia in women, and I don't think that's necessarily always the explanation. And I think this study kind of further emphasizes that by showing some of these objective measure differences. So more biology studies to better understand this would be important.
Okay. Eric, what else got your floated your boat on this this meeting here from the just looking at the psoriatic arthritis?
Well, I mean, I did mention the one new drug, which was sort of interesting because we've been kind of waiting for it, is the deucravacitinib, or I know you have a different way of pronouncing it, but that's okay. It's a TYK2 inhibitor. So we've gone down the path of JAK inhibitors, and the JAK family has 4 different major molecules in a JAK 1, 2, 3, and then TYK2. And I don't ask me to explain how that happened, but it did. And the kind of claim to fame here is that interleukin 23 seems to signal preferentially through TYK2 as opposed to the other JAKs. And we know that there's a lot of intermixing with JAKs and cytokine signaling. And it's a mistake to assume that a JAK target is going to stop one cytokine. But that IL-23 has turned out to be a really effective treatment inhibiting IL-23 for psoriasis. And so it poses the possibility that an oral agent that blocks IL-23 signaling could be particularly good in this space. The psoriasis data was good. It wasn't kind of the same kind of level that we're used to seeing with the IL-23 antibodies, which are approved. And this was the first data in psoriatic arthritis, a phase 2 study. And the drug clearly worked. But again, the skin response was good, but it didn't look like the kind of skin response that you would see if you had an IL-23 antibody, which doesn't mean it's a bad drug. It just may be not getting to the place that, one might have hoped, thinking about the mechanism. That was kind of the hope for this agent. But it was effective. It worked on skin. It worked on joints. very well tolerated. Seems to have a very good safety profile. So more to come, but we'll see.
One of the interesting safety things to me was the acne. So that one of and we were talked about this a bit, is this just because it's dermatologists picking up acne? Why is that different? We don't see that with other IL-23s. We don't really see that as much with the JAKs. So it's kind of interesting, and it will be interesting to play out in the phase 3 studies.
Yeah, there was acne in the psoriasis study, and it was definitely skewed towards the treatment arm and not the placebo arm. And I went back and looked at the paper, and they postulated, that maybe it had some effect on the skin bacteria that sort of are involved with acne and did that. But it's all speculation. I don't think anybody truly knows. There's no good mechanism.
And you say acne, but boy, I'm surprised. I'm not surprised. It really bothers people. That little bit of steroid and they get some acne,
Right.
and that's all they want to talk about. Is the acne.
And
It's like I'd rather have the psoriasis.
Right. And we don't know how much acne they really had. Was it a
Right.
significant, as Alexis said, they were dermatology studies. Dermatologists know acne, right? And so a little bit they would have picked up and said, yeah, there's some acne here, but I don't know how significant clinically that was. We don't know.
So will TYK2 parallel the development of all the IL-23s, the tildrakizumab, the mirikizumab that, they're in skin trials that just been reported or approved. And is that why TYK is going to pave the way? I mean, it's phase 2. It gave a 60-40-20 sort of response. That's all well and good. But I think that they need to go to the next level. One, to look at this particular side effect, but also to show that they really are going to have the staying power, either with the skin or with the joints.
I mean, it's not going to be any better for joints than anything we have already. I mean, because look, it's a phase 2 trial that's 60-40-20. That the phase 3 trial isn't going to be better than that, and it may likely be not as good. So it's going to be good for joints. The question is it better? What's the hook? Is it better for skin? Is it safer overall? Why?
Well, I think they're hoping for a filgotinib-like sort of angle that they can make the claim, yeah, we work, but look at our safety data. Boy, our safety data looks really, really good. And I'm just speculating right now, but obviously, but I've got, I'm sure you do too, plenty of people that are taking the approved JAK inhibitor and doing great with their skin and their joints with really problematic disease. So, that's what you're looking for.
Go ahead, Alexis.
I have a feeling the target here is going to be apremilast. And in fact, in the psoriasis, the skin trial, they compared to apremilast that they haven't published yet, but just had a press release for. So I think that might be the market they're going to target too for this. I don't know. I mean, this is all speculation as well, but I think that may be where this lands.
So Jack, I was going to have to follow up on that. You've been on the FDA panels. How much evidence will they need to say you don't need to check lab tests? I mean, that's apremilast big niche. That's a big seller for that drug, is you don't have to check blood tests. But this is a JAK inhib, and JAK inhibs you have to take blood. So what's the threshold? I
think they go into this. Well, Artie, it's just like when you were on the FDA session at the ACR meeting, along with Nikolai and others, and I asked him, how's the TYK2 going to be treated as far as VTE risk? And he kind of went like this, but what he was saying was, it's going to be treated the same until we learn otherwise. So they're expecting that this is going to be a lab monitoring drug. And of course they have to do the labs, but they're going to have to show apremilast-like safety in labs where nothing budges. The CBC doesn't change, the chem profiles don't change, there's no lymphopenia risk, there's no CKemia that people are worried about, the lipids are not an issue. They got to prove a lot, and I think that's, I'm a betting man, I'm not betting on that.
Well, and let me ask Alexis and Eric, because a difficulty is in PSA, I think you see less problems lab-wise than you do in RA with the JAK inhibs. Everything is a little bit better, right? I think the CK signal is less, and so I think you're proving it by disease, because there's no. I mean, deucravacitinib may go into lupus and other diseases, but I don't think it's not going to go into RA that I'm aware of. So where are you going to get the comparator?
Yeah, I think the LFTs are always an issue in psoriasis and PSA because of their fatty liver disease. So we'll see if this has an impact.
Yeah, I sort of agree with Jack. I mean, I think that, apremilast got got a pass because they didn't see any issues, and it had nothing else that was sort of comparable, and they could say it's a different drug. So the only way, even if they don't see any lab abnormalities, and even with the VTEs, the only way they can get that past the FDA is to say, no, 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 it's a TYK2 inhibitor. It's not a JAK. And we don't really consider it a JAK inhibitor because I mean, look at upadacitinib, right? No VTEs in the clinical trials at all, no signal whatsoever, but the label carries that risk that is pulled over from the other drugs. And so it's really going to come down to whether the FDA decides this is the fourth JAK inhibitor, this is the fourth JAK molecule that we're inhibiting, or they're willing to say it's a different molecule. It's a different.
So they'll say, no, we're not a JAK inhib, we're a ticinib.
That's exactly right. It's a ticinib.
Yeah, and we're presenting 2 doses for you for your consideration, just like all the other JAKs that didn't get 2 doses.
I don't know. We'll see.
Right. Well, we're waiting on filgotinib. They got 2 doses in Europe. I'm betting they will not get it whenever they get approved, 2021, 2022. They got a few hurdles to jump over before they can go up for consideration again.
So Jack, I think we're about at the time that we're looking at. You want to anything final, or you want to run the panel, the final thing, or I think we're almost at the time.
I think that this was really an interesting discussion, and I think that the one thing that this panel of experts on psoriatic disease could tell us is what's the best way to treat enthesitis. Let's go around the horn. Alexa, you want to take a stab at that? Alexis, I'm sorry.
I think in addition to treating the whole disease, with a biologic or whatever you're treating with, I do think that actually physical therapy, rest, as needed, and sometimes for the Achilles in particular, a boot is sometimes needed, especially when it's really robust, and NSAIDs. So I think that treating just with a DMARD, CSDMARD, whatever you choose, is not enough. I think you have to do the conservative route as well.
And if you're asking for treatment, Jack, I mean, all the biologics work well on enthesitis, and I don't see a distinguishing feature there.
Okay.
Alexis stole mine. I was going to say non-steroidals.
Yeah. The other thing
old school.
The other thing that wasn't at this meeting, but is sort of trickling in the background, is the first part of 2021 is the year of JAK inhibitors for spondyloarthritis in general. That we're going to get upadacitinib now all of a sudden for psoriatic arthritis. We're going to get upadacitinib for ankylosing spondylitis. We're going to get tofacitinib for it's the first 6 months of next year is going to be JAK inhibitors in spondyloarthritis like it was in RA a few years back, and the use in RA has kind of set the stage for that. So I think it's going to take over even faster.
So I have one more question I got to get in from, because you guys are the experts. What do you think of the TycoSpa study? I mean, tight control in spondyloarthritis, and usual care was as good as tight control in the primary endpoint. What's the deal with that?
I think the primary endpoint is the deal with that. So I think that, if you're targeting disease activity along the way, but your outcome is something different. I mean, I understand why they chose that, because that you ultimately want to improve how the patient feels. However, how the patient feels in terms of their quality of life is impacted by many other things. It's a multifactorial outcome. And so now you kind of gotten one piece into a big piece. So I'm not sure that that's the best way to look at it. Clearly they did better overall, but it just didn't meet statistical significance.
I'm skeptical about tight control and axial SpA altogether, because one of the goals for tight control in rheumatoid arthritis has always been, better long-term outcomes, less structural damage, better function in the long run. And when we're working with drugs that we just don't know truly change those outcomes, I mean, the structural benefit from biologic therapy in axial spondyloarthritis is, if anything, very tiny. And I'm not even convinced it's really that in a lot of people. And so it's all about symptoms. And, when you treat somebody, then the Brooklyn hack is good enough. If you're doing symptoms and the patient says, I'm good, then you've treated their symptoms. They're in tight control. And doing a measure that puts a number on that may not get you any further.
I think that the most notable thing to me about the presentation of that was it was incredibly cost effective. Insanely cost effective. It was like a couple of $1,000s for a quali.
I know.
Although if you don't count the biologics nor the visit costs, you get extremely cost effective. So,
Wait, the biologics that cost how much? I mean, you have to count that. So
They don't. I mean, that's the problem. And there's just no way to believe that it's cost effective in the US with the cost of the biologics. Any study you have,
point. That's a really good point.
to have more people on biologics. You know, if you go to a tight control approach and it's set up to drive more people to biologic use, it's going to be more expensive. The problem is the tight control there in Europe and in countries in Europe is the cost analysis is different because they can roll in societal costs. Are they at work? And in the US, that's a separate issue. That the cost, the cost savings by keeping people at work and not out on disability or not out on short-term leave, that doesn't get accounted for in your insurance costs and the cost of treating somebody. And so there's just no way to put all that together. And given that, if you don't account for that, there's no way the tight control with more aggressive use of biologics could possibly be cheaper.
yeah, it's not.
All right, well, Jack, you want to wrap us up?
Yeah, I want to thank this panel of psoriatic experts and contributing greatly to the Room Now audience. So, and by the way, you all look wonderful, having just survived a 4-day virtual meeting. It's just sort of amazing. So, congratulations on all your hard work.
Fun meeting. Thank you, Jack, by the way. Room Now has done a great job during this meeting, and the coverage was phenomenal.
Yeah.
Phenomenal.
All right, enjoy.
Have
All
a
right,
good, bye.
All right, folks.
see you, sir.